Good afternoon, everybody. I'm a clinical researcher at Keele University and a GP. So the purpose in this presentation is really to illustrate a example where we used locally to identify specific long-term condition pairs. To use that in a profiling process, but which also allows cost estimation. Now, this work arose out of academic partnership with local commissioners and intelligence and public health teams to develop better methods for targeting interventions. So in this session, what I intend to do is give you a brief overview of one practical approach that we've looked at comorbidity. This results were published in a national journal. Clinically, in the databases that GPs use in practice, there may be specific multimorbid pairs that we can identify. And by linking it to other data, such as accident and emergency data and hospital data, we can look at transitions in care and also costs. And in this particular project, we did that for a 3-year time period. And we think this is a way for considering long-term condition care, both in terms of identifying multimorbidity type, linking information across healthcare interfaces, and providing an opportunity for targeted intervention. The first thing I want to start off with is by clarifying the definitions. People may have heard of the term comorbidity and multimorbidity. These two terms are linked and are interchangeable, so it should not confuse you. In terms of comorbidity, what you're really interested in is an index condition and what having other conditions does to it. So if you have diabetes and have lots of other conditions, the question there would be, what does the comorbidity do to your diabetes? The multimorbidity is really about multiple conditions. And there, what we're really interested in is the fact that a lot of old people have a number of multiple conditions. So it's not the number and type, we're just interested in the fact that people have many. Now, as soon as you say multiple conditions or comorbidity, invariably the first question is, how many do you look at? So I think there is a simple way to look at this and a complex way. And in this slide, I'm going to give you a couple of examples of that. So people have looked at specific combinations. There's a lot of good evidence on chronic disease and depression and how to effectively manage that. There's a lot of good evidence on the fact that people who have diabetes, heart disease, and cardiovascular problem, that they cluster together. And so that is a type of multiple morbidity. The other way people have done looked at comorbidity or multimorbidity is to look at counts, simply counting the number of conditions people have. But the problem there is just counting doesn't give you an idea of what the person has. So a person count may have cancer included in that, but another person's count may have depression included in that. We have developed more sophisticated measures to look at this issue, and some of you may have come across classification or risk scores. So you may have come across BUPA risk score or Johns Hopkins ambulatory case mix. In our own work, we've developed our own classification in general practice at Keele. The purpose in this risk score is to identify people with multiple morbidity. And so, for example, sometimes we use this to identify people at risk of admission. There are also more advanced methods of looking at statistical clustering, and I shan't go into that because that is still where research is emerging. Now the question becomes, how many do you include in your healthcare activity? Do you go for a simple approach or do you go for a complex approach? And I guess in the end, it depends on what the question is and what you're trying to change and address. Locally, our team took part in the Year of the Care project. And we used the complex BUPA risk score approach, but we also devised another approach, and this is what we call the pairs approach. We know a lot of patients with long-term conditions are engaged in single disease pathways. We also know GP practices routinely have long-term condition registers. And it's by using these registers we can identify indicator pathways that the patients might be engaged in. Now, we didn't want to develop a complex model. We wanted to test a simple way of looking at it. So this is where we thought, shall we look at specific pairs and see whether these indicate the likely healthcare use and costs. And we linked the GP registers to A&E data and hospital data for a 3-year time period. So in this pairs approach, we did an empirical test. For 53 local general practices, we identified 60,000 people who were aged 40 years and over. And these patients had one of 6 long-term conditions. The 6 long-term conditions being hypertension, diabetes, coronary heart disease, chronic obstructive pulmonary disease, chronic heart failure, and chronic kidney disease. We linked the registers to A&E episodes and costs, and hospital admissions and costs. And what we wanted to test was if we ordered these examples into specific pairs, could we predict the likely cost? So could we risk stratify by long-term condition status? When we link the data, the registers to the A&E data and hospital data for 3-year time frame, just to be clear, we defined A&E attendance for a 3-year period as attendance none in 3 years, at least once in one of the 3 years, at least twice in 2 of the 3 years, or at least once in all 3 years. So the A&E data is not the total number of A&E episodes, it's basically whether the person is attending in each of the 3 years. We use the same approach for hospital admissions. And we also then total the costs for A&E and hospital admission costs for the 3-year period. Now in this presentation, I'm really going to focus on hospital admission costs because those are much higher than the A&E costs. So these are the results, and I'm going to first, in this slide, show you 2 example pairs and transitions in care. So on the left side of the slide, you have the hypertension and diabetes example. And what we did for the population was we said which people had both, which people had diabetes without hypertension, and which people had hypertension without diabetes. So by using this approach, we were able to compare the pair effect, so the diabetes and hypertension. And what this showed in terms of A&E episodes is if I look at the bottom row, hypertension, diabetes, 63.4% had no A&E episode, but that means 37% had had at least one A&E episode in any one of the 3 years. And the bottom row gives you figures of people who have had A&E episodes in each of the 3 years. But if you then compare it with the hypertension group, 32% had had an A&E episode. So just having diabetes and hypertension was associated with increased A&E attendance, but it was similar to the diabetes group. But on the right side, for contrast, I've picked out the heart failure and chronic kidney disease group. Now here, in comparison, what you see is 67% of people with chronic kidney disease and heart failure had had at least one A&E episode. So 67%. If you had chronic kidney disease without heart failure, 58% had had no episodes, which means 42% had. And if you had heart failure, your likelihood of A&E episodes was much lower. So what this slide illustrates is having multimorbid pairs indicates the likelihood of A&E episodes. And by also having comparable groups, it shows you the level of transitions in care. In this next slide, for the same two examples, I'm now showing you the hospital admission episodes. So if you look at the multimorbid pair of hypertension and diabetes, half this population had had at least one hospital admission in any one of the 3 years. Just to be clear, the hospital admissions could be planned or unplanned. But if you then looked at the diabetes without the hypertension, 46% had had hospital admission. So if you have hypertension, diabetes, you're more likely to have an hospital admission. And if you had hypertension without diabetes, 46% had hospital admission. So having the multimorbid pair is associated with more likelihood of transition in care for hospital admission. Now on the right side, at the other example of a multimorbid pair, chronic kidney disease and heart failure, 80% of this group had had at least one hospital admission in any one of the 3 years. And you've got comparable estimates for the other groups. If you look at the paper, which is available online and easily accessible, this data is also given for the other multimorbid pairs, and there's a gradient. So if you have hypertension and diabetes, although you're relatively more likely to have hospital admissions, it's not as high as the more severe group of people with chronic kidney disease and heart failure. So these two slides show you transitions in care over a 3-year time period for specific multimorbid pair. In the actual analysis, we also then looked at the different multimorbid pairs and the associated costs. Now, whilst the number of pairs for this selected long-term condition could be many multiples, what we really wanted to look at was, for these specific categories, could we look and observe a gradient in costs? The other thing in this analysis we also wanted to do was adjust for other things that might explain some of the costs, such as age, gender, deprivation. So in this slide, we also adjusted the hospital admission costs. And just to be clear and emphasize, we focused on the hospital admission costs because those were much higher than A&E costs. But we were interested in A&E episodes as a point of intervention. So in this slide, to return, the top 3 rows for the hypertension and diabetes multimorbid pair, the average costs for the 3 years for this group were £2,300. For the diabetes group without hypertension, those costs were marginally lower. And for those people with hypertension without diabetes, the costs were around £1,600, and those were 3-year costs. In the brackets, you have the figures, which is something called standard deviation, which is the spread of the costs. And what this shows is, although these are average costs, there is a large variation in terms of total costs. But we wanted to understand that if you identified this population, what would be the average costs? In the next column, then we adjusted those costs. So in this particular analysis, the hypertension group without diabetes is the compared group, so it's 0. But if you have diabetes without hypertension, your costs on average are £600 higher. But if you have hypertension and diabetes, those costs are marginally higher. And in the final column, it tells you whether these were statistically significant. So that's the hypertension and diabetes pair. And then we repeated the same process for diabetes and coronary heart disease. The average costs were £3,000. Diabetes and chronic kidney disease, the average costs were £3,600. If you had COPD and heart disease, your average costs then go up. The group with chronic kidney disease and heart failure, your average costs were the highest, £5,300. So these escalating costs show to us that the multimorbid pair can give you indicative average costs for a 3-year time period. And it gives it for the population. What you have to appreciate is there are still large variations in costs for the individual patients. And then if you then return to the final column, the third column, the adjusted difference in costs. So if you have heart failure and chronic kidney disease, your costs on average were £2,000 higher than if you had heart failure without chronic kidney disease. Here, people might appreciate that chronic kidney disease high costs are probably linked to something like dialysis, people who are on dialysis. But then if you look at the heart failure and COPD group, the average costs were £2,000 higher than if you had COPD without heart failure. So having heart failure and COPD really escalates your costs. And people can then look at the different rows in terms of cost differences. And as I said before, the final column is whether these were statistically different. Now what we think is the results suggest that the multimorbidity provides one way of risk stratifying populations. It doesn't help you identify the individual, but it forms a basis for using the long-term condition registers to identify and case find people with a multimorbid pair and the potential costs. So in summary, I hope this session has given you a brief overview of one practical approach that we have devised at looking at comorbidity. I wish to emphasize we have used it in combination with other approaches such as risk stratification scores. And we've also used locally in terms of individual case finding. So this method is an enhanced way of complementing other approaches. We published a study to show how case finding can be informative of costs and potential costs of the future. I think our results show that in these particular examples that you can highlight the differences in cost and transitions in care. And I hope this is one way in which you might use in your long-term condition improvement program, and especially the potential of linking information across healthcare interfaces for targeted intervention. Thank you.